Hello, everyone. Welcome to the webinar. Today, we have a discussion about how ACOs can revolutionize care through integrated behavioral health. I'm James Kanka. I'm the VP of Marketing here at NeuroFlow and your host for today's webinar. Over the next 45 minutes, we're going to discuss how ACOs are leading the charge in launching successful integrated care programs. And we're going to share some lessons that all healthcare organizations can incorporate into their integrated strategies. It's not just ACOs, but we are going to focus on ACOs. If you know a little bit about NeuroFlow, we serve both health systems, ACOs, payers, and even military and government organizations to help them integrate behavioral health into their organization, powering their programs. And we're going to get a little taste of that today as we focus on ACOs. Before I get started and introduce the speakers today, I wanted to go through some housekeeping items. Number one, we are recording the webinar. This is a big question we always get, so you don't have to worry about it. We are going to send out that recording to you after this in the next few days. And then number two, this is designed to be a place where you can ask and join in the discussion. The first 30 minutes, I have some questions that I want to ask that relate to what we talked about earlier. But then the last 15 questions are all about you. So if you have any questions, please submit them in the question portion of GoToWebinar. If we don't have a chance to get to them in the 45 minutes we have today, we can follow up with you as long as you leave your contact information there. But I really encourage you to submit those throughout the discussion if something strikes you. And if we can, we will definitely get to them. It means a lot to us. All right, today we are joined by Dana Fondell. Dana is a behavioral health integration consultant in Philadelphia. We're also joined by, let me advance the slide here so you can see them, as well as the video. We are also joined by Dr. Jim Barr, who's the VP of Physician Value-Based Programs and the CMO of Accountable Care Organizations at Atlantic Health System. We also have Dr. Tom Zobler, who is joining us. He's our Chief Medical Officer at NeuroFlow. And I would love for you to give a little bit of introduction yourselves. And Dana, let's start with you. What is it that you do? What's your experience? Why are you joining us today?
Great, thanks so much, James. So I am a public health nurse. And my work really focuses on strengthening and integrating and innovating services across the healthcare safety net. So early in my career, I was lucky enough to work at a federally qualified health center that was an early adopter of an integrated behavioral health model. And since then, I've worked in various settings, such as community health centers, for nonprofit payers, in refugee camps, and with startups. And a lot of that work has focused on integrating behavioral health into primary care services, or taking principles from chronic disease management and really using those to inform evidence-based practice within behavioral health care. So some of the different projects have involved integrating licensed clinical social workers into diabetes care management initiatives, patient-centered medical home transformation, and really creating trauma-informed primary care models. Most recently, for folks that are in New Jersey, I worked at the Camden Coalition for about 5 years, launching and supporting the piloting and scaling of substance use and behavioral health services, especially for publicly funded patients, primarily focused on Medicaid. Now I'm an independent consultant and really work at that intersection of medical, behavioral health, and social supports.
Thank you. Dr. Jim Barr, would you mind sharing a little bit about yourself?
Sure, James. Again, I'm a trained family physician, practiced in my own practice for about 32 years. Now I fulfill the role of a Chief Medical Officer for the Atlantic Health System's Accountable Care Organizations. We have 3 that we manage. Those ACOs consist of over 3,500 physicians. About 1,000 of those are primary care doctors. We have about 518,000 patients that are attributed to us through Medicare, Medicare Advantage, and commercial arrangements. And we've been in the ACO business from the start, starting back in 2012, and have done extremely well with our annual targets of the AAA. And at this point, in the last 2-3 years, though, really started to push our whole person orientation, further engagement of patients. And that's where our behavioral health initiatives have grown.
Great. And Dr. Tom Zobler, would you mind giving a little introduction to yourself, some of your history?
Yeah, thank you, James. Hi, everyone. Nice to be here. Looking forward to the discussion. Tom Zobler, I'm a psychiatrist, chief medical officer at NeuroFlow. I've been at NeuroFlow for about 2 years. Prior to that, I was a department chair. In fact, Jim and I worked in the same system. I was a department chair for 21 years, psychiatry department chair, and have been immersed in the world of integrating psychiatry and behavioral health into a multitude of medical settings for just about 3 decades. I was on the faculty at University of Washington in the 1990s. I was very fortunate that my mentor, who was really a lifelong mentor for me, Wayne Caden, was the guy who originated collaborative care. So I've been seeding that model in different places throughout the country, including at Atlantic Health before I came to NeuroFlow. So look forward to the discussion today. Pleasure to be here.
Thank you so much for joining us all. I think we have a great discussion today. Let's start off. Tom, could you set the stage for us? Why are integrated care models so important to ACOs? And then Jim and Dana, if there's anything else you want to add, please add on to the end.
Sure, thanks, James. So let me just say, Jim, Dana, keep me honest here, but when you think about what ACOs, what the core mission is of ACOs, it's providing comprehensive, coordinated care, really looking at high value, high quality care and resource utilization, so it can be done at a lower cost. Really, the triple aim or quadruple aim, if you take into account provider satisfaction, and now we're also looking at issues around equity. The reality is you can't do all of those things if you don't have mental health and well-being among the population that you're serving. You simply can't have overall health without mental health, and the statistics are really quite striking. There was a study done by Milliman in 2020 that really drives this home. There are 21 million insured patients, and among that population, they looked at the 10% of highest utilizing patients that account for about 70% of all healthcare costs. So we know that their 20-80 rule, 20% account for 80%. This was the 10% that account for 70% of all healthcare costs. And the annual spend for healthcare costs in that 10% was about 42,000. It was 21 times the amount for the 90% of the population that were not distressed high utilizing. When you break it down and you look at that distressed high utilizing population, 57% in this study had psychiatric illness. That's about 6% of the total population, and that 6% accounted for 44% of all the healthcare costs. So it's a lot of statistics, but the message here is that one, psychiatric illness drives increased utilization. We know that that depending on the illness, the multiplier can be anywhere from 2.7 to 6.2 times as much when you compare people with and without psychiatric illness. So the costs are enormous. It's estimated at about $406 billion annually. In addition, additional physical healthcare costs are associated with underlying psychiatric illness. So the costs are enormous. And what is particularly striking is that when you look at how well we treat psychiatric illness, well, about 60% of people in any given year, of adults, 60% receive no care whatsoever. About 80% of children receive no care. For those who have an underlying psychiatric problem, receive no care. About 90% of those with a substance use disorder. In that distressed high utilizing population, that 6% in that Milliman study, and that was one of many studies, just a particularly well done study, in that 6%, remarkably, the average spend for total healthcare dollars annually in that distressed high utilizing population with co-occurring behavioral problems was $44,000 annually. It was half that group had less than $100 annually in their spend for their psychiatric problems. So we're simply not treating the underlying psychiatric problem. We're not even psychiatric problems. We're often not surfacing them. And when you look at the core principles of behavioral integration, I think they really apply to what ACOs are all about. So one, it is team-based care, right, which is a core principle. It's patient-centered care. Those are core principles. And then when you look at quality, evidence-based, measurement-based care, those are core components of behavioral integration. That you follow an evidence base, and there have been many randomized controlled trials with collaborative care, over 90 that speak to the evidence base. We know that measurement-based care is critical to really collect outcomes and see how patients are doing. Beyond that, it's population-focused care. You need to look at the health of populations and track how they're doing and look at how costs are being reduced when you provide better quality care. And it's accountable care, which of course is true for accountable care organizations. No one can fall through the cracks. People have to be accountable for the quality of care, the lowering of cost. So those core principles of behavioral integration really apply, I think, to ACOs. And so I think there's tremendous overlap in the work that's done with behavioral integration and ACOs. And I think to have a successful ACO, you really, and I'll defer to Jim and Dana on this, but you really have to take into account the behavioral health of the entire population and make sure you're surfacing the underlying psychiatric problems and addressing them.
Anything you guys would like to add to that?
Go ahead, Dana.
Yeah, I mean, I just to echo what Tom said, I mean, I think that we know that the outcomes are poor for people that have severe and persistent mental illness. And we know that so many of those people are not being served and that they're driving the costs. And when we talk about the scale of it, I was looking at the 2020 National Survey on Drug Use and Mental Health, and 21% is the current estimate of the number of people that had a mental health condition, such as anxiety, depression, schizophrenia. 21% of the US population has something that we know we are not appropriately treating, and that our current care model is still resulting in many people dying with having life expectancy up to 20 years lower than other individuals who don't have those diagnoses. I mean, just the scale and the magnitude of the problem, it means that there's a lot of room for innovation. And echoing what Tom said again, I just think that the different components of the population health level are so aligned. I was reading a study that showed that ACOs that actually adopted collaborative care or an integrated care model, which Jim and Tom are experts on, they were also more likely to implement a whole suite of evidence-based protocols that just naturally follow an integrated care model, like having care managers, patient registries, looking at co-location and coordination of communication around co-management of patients. So I just think that it's such a low-hanging fruit, and it's such a natural starting point for an ACO to really go into an integrated care model, and it fits well with that whole suite of services. One last thing I would just say, that it's not necessarily why ACOs should do it, but this is, in my experience, what patients want. They want integrated care. I've run different initiatives where you're engaging folks at the emergency department who are seeking services for behavioral health, and when offered choices about where they could get follow-up, patients across the board are like, oh my gosh, could I get care with my primary care? That would be easier. I know how to navigate it. My kids feel comfortable there. I mean, it's just the natural place. And when you're looking at lowering the barrier to accessing care, an integrated model just makes sense.
Yeah. And I'll just add that, again, if we look at our own story, going back 12 years, where we get to here right now. I mean, early on, great success right out of the gate with patient-centered medical home model. Again, Tom, team-based care models, American College of Physicians specialty medical neighborhood type model. We took all those models, had the physicians just transform their practices and work at level of licensures, and wow, we're doing great. And then it's like, wow, we need more data. So we fired about 3 different vendors who tried to say that they could give us all the data and insights they could give us. None of them could. So we built our own in the AWS cloud, our own data and analytic and reporting platform. Phenomenal amount of data. We have about 300 terabytes in there right now, and we could detail almost every single disease state, every provider, who performed at what levels. Fantastic. Got us another step or two along the way. But there's still something missing. And then, of course, COVID hits. And the burden on our practices, especially our primary care doctors, the burden on our patients, the behavioral health plague pretty much just took off. And we realized our whole agenda, which used to be, okay, use data and analytics to find the highest cost patient. Now let's predict the next one. Let's use the data scientists for predictive and prescriptive type analytics. Okay, great. But that worked fine in the past. We still did not engage the patient. We had to switch around, and we also had physicians burned out. So we switched around our entire priorities from using data to go after the top patient or predict the next one. We switched it all around. The number one thing we did the last 3 years, from 2020 on to 2023, was number one, every bit of our efforts, no matter what it did, it had to achieve an unburdening of our physician practice. Number two, it had to provide access to an extended primary care practice. By extended or advanced primary care, it means integrating with behavioral health therapists, psychiatrists, nutritionists, pain management people, whatever it was that was going to be part of your extended team. That was exactly where we had to go for access. And number three, then we saw, did it improve our patient outcomes? Okay, so it was like, boom, we're not treating numbers, we're not treating diseases, we're treating people. That whole person orientation, that patient-centered medical home, the most important principle of that medical home model is that whole person, and that's where this integrated care allowed us to go.
That's a really powerful decision-making framework. I hadn't heard that yet, so I'm glad you got to share that here. So the question is that help you make the decisions for what you're looking for. I want to follow up with you, Jim. What did you do to allow your ACO to be successful in this? What kind of experiences, what lessons did you learn in bridging this process?
You mean what scars do I have?
Yeah, I want to hear the scars.
Nah, it's, you never want the top-down approach. That's, other entities use that approach. So, when you're doing anything like this, you need to have it from the bottom up. So obviously patient input and physician input. You have to listen, you have to find out what are the pain points, what are the use cases that we could help solve to, number one, unburden you, number two, improve your access and be able to share your load with others. And yet it's got to be done in a very coordinated, integrated fashion that the patient still uses you, the primary care provider, as their most trusted and most respected part of the health system. Because that's what, no matter what surveys you look at, what's the patients want the most out of their healthcare system? A trusted and respected source that they can rely on. So that's where we liked this model. We had good use cases and buy-in from the physicians, and especially the physician leadership. You got to go for your leaders, okay? And then, of course, you engage the leaders of your health system, your senior management, whatever else you need. Of course, your IT team, data team. So we brought it all in. The legal team and the cybersecurity team are valuable participants in this. And that's what I'm going to leave it at. But you will have to go through that whenever you're bringing in a partnership from an outside entity, especially one that involves patient data sharing. So just be prepared.
Well, yeah, what kind of expectation do you have on timeline, or would you give others? How far in advance do they need to be thinking about this?
Let's be kind and say, look, plan at least 3 months on your cybersecurity and legal review. It could take longer, okay? But it's a new process for a lot of health systems and legal teams and IS teams. So yeah, you have to educate them and make them aware of what's going on. So that would say, if you had to tell me what's the rate limiting step that you have to really prepare ahead of time for, do that one, the legal and cybersecurity concerns. And I'm not talking about just integrated collaborative care models with behavioral health. It's just about anything right now. That is huge to be able to be prepared and do well. And then from there, yeah, fine. You can get your team selected for that landing phase. I mean, team of practices of our population care managers at our ACO who are going to support this. Everybody lined up, our measurements, milestones, and everything all lined up, and you're off and running. I think the beauty of integrated care is you're not disrupting a practice, because right now we have tons of disruptors out there that come into primary care especially, and it's scary for a lot of the practices. There's a lot of money being thrown around too, but then you give up total control. And so this was the beauty of this model. It was no, we're not trying to take control away from you. You're still the number one secret sauce we have, that magic you have within your physician or provider patient relationship, that we are not going to touch. We're going to enhance it. So with that kind of messaging, again, the engagement, adoption, you're doing the right thing, and it just took off. So, but enjoy your legal and IT teams.
Thank you for sharing that. So you spoke a little bit of it, but I'd like to ask you, Dana and Dr. Tom Zobler, what are the key components that you think make integrated behavioral health programs successful? And I'm curious, to follow on that, Dr. Barr, if there's anything that had to check the box at the end there, like it was a no-go, it wasn't going to work, it wasn't going to reduce the burden on providers or anything like that you're looking at. But let's start with you, Dana.
So one thing that I think really makes a program successful is building on what Jim said about the trusting relationship. I really think that the primary care office can be a trust broker to really normalize the interconnection between mental health and physical health. I think that we're in a current time where people are more willing to talk about mental health and accept referrals, but there are still challenges around stigma. And so I think having your primary care teams be equipped to have conversations that explain the interconnections and the ways that mental health impacts chronic disease and physical symptoms, and the ways that physical symptoms and chronic diseases impact mental health. We know that if you have diabetes, you are more likely to develop depression. So just ways that help kind of break down some of those false silos that we've really put up between mental health and physical health. Another thing that I think can really make it successful is again, building. I think that Jim explained such a good example within AtlantiCare, but the ways that technology can automate things and really unburden staff so that more time is spent on those conversations or on explaining the rationale for a referral versus the decision making about having to make a referral or how to make a referral or who to make a referral to. So I think that technology is really a beautiful tool to automate it, both for unburdening physicians or advanced practice providers, whoever's having that conversation, but also to make sure that everyone who meets criteria is actually getting referred to behavioral health services. There's a lot of conversation around equity and around how do we try to use technology as a tool to eliminate bias within our systems, and it can be a really good method for just making sure that a referral isn't dependent on a provider or a care team member remembering or thinking that person will engage and therefore only making the referral. I think technology can really kind of supplement and support the automation of that process. Yeah, I think those are the kind of two keys for success that I just really wanted to highlight.
And I would pick up on both Dana, what you were saying, and certainly echo, and I know we'll have time to talk about technology. And Jim, you touched on this as well, but I think, first of all, you need to have commitment by the organization and by leadership, right? That's, Jim, I know you touched on this, but that is just mission critical. Because if you don't have that commitment, there are challenges, and it's very hard to implement this without an understanding of what it entails and without commitment from the very top. So while on the one hand, this has to be a process where all stakeholders are included, and I'll get to that in just a second, you got to make sure you have that commitment. So that's one, and there are many ways of doing that, but that's key. Two, there's a huge cultural chasm between how physicians in medical, in primary care and medical specialties, and how psychiatrists think about illness and how they treat illness, and how health systems often silo behavioral health. There's a whole history, right, where behavioral health treatment was literally siloed from mainstream medicine. That's unfortunate, and we're now trying to change that dramatically. There are still many states where you can't have a physical medicine provider and a behavioral provider see the patient on the same day, and so there are a lot of challenges. So a big part of this is developing a team. An interdisciplinary team, which is needless to say going to be comprised of behavioral health experts, of medical experts, whether we're talking about primary care, specialty, subspecialty care, oncology, cardiology, a whole range of disciplines can do this, but it's really important to build that team and make sure you define the roles and make sure you define a common language and vocabulary, and there's alignment on what outcomes you're tracking and the fact that you are going to be tracking outcomes. That's really important. And there's also got to be a process to continually assess how that team is doing, because that multidisciplinary care is not really new to medicine, but involving it in this integrated fashion where teams are functioning seamlessly to provide, as Jim was saying, whole person care. That holistic care is actually somewhat new to a lot of systems and a lot of providers. So there has to be a process to continually track that, and then you got to track outcomes, and you got to track outcomes in a way that everyone can interpret them together and make sense of them. So those are key characteristics. I will add that having done this for literally 30 years, well before there were collaborative care CPT codes, what I can tell you is that when collaborative care is done well, the results, and we know this from over 90 randomized controlled trials, that's just one type of behavioral integration, but it's the one that's been most well studied. But the thing that is also particularly striking, in addition to the outcomes that are very positive and the patients that benefit, provider satisfaction goes way up. So it becomes a situation where when you want to retain your primary care docs or subspecialty docs or whatever, provider satisfaction goes way up. So quality of care improves, physician satisfaction improves, equity in terms of providing, democratizing access to behavioral health care and making sure that you can whittle down that large percentage of patients who are not getting care. This is universalizing the care and ensuring, in part through technology, that everyone gets identified and gets treatment that they very much need.
Yeah. And I would just echo some of those three boxes that you said, James, as far as what would you have to check off to go ahead. Yeah, I already mentioned, again, it's got to reduce the physician workflow, their burdens, which again, a lot of people mistake this as being only something we use in someone who has a behavioral health diagnosis. And no, we are enrolling all ACO patients because this takes off my plate as a family doctor, my need to do screenings, okay? And then when the screenings, okay, borderline, positive, so the education of the patient, the coaching, the motivation, the tools, resources, journey. Do I have time for this as a primary care doctor? No. So it is definitely unburdening, number one. Number two is you also got to make sure you also check off that business case, financially, okay? So, we're all like hoping, yes, at the end of the day, everything's going to help shared savings go into the millions of billions of dollars. But no, you also want to look at your other business cases. There is fee-for-service revenue in the collaborative care model, okay, that, insurance companies will reimburse. There is, penalty reduction, readmission rates go down. Whoa, look at those penalties go down. So you got to pull out that business case. So then you check that off, and your CFO is going to make sure you have that one checked. And then, of course, the last thing that Dr. Zabler just mentioned is, can you measure the outcomes? You got to make sure you have no room today for anything that's neutral. Certainly nothing that's negative, but it can't even be neutral. I would even say it has to be, it can't be a 1.5 to 1 return on investment. No, it's not worth. We have no time, no resources to dedicate. So it's got to be something we can measure and know that we're doing something impactful, because if not, we're going to stop it.
I like that. It's got to be like a magnitude difference in order for it to be worth the time and investment. And also, you noted earlier, it's a really kind of a population health approach earlier. So it's not just for those that you've identified already, it's for the whole population. That's great.
Everyone.
So I want to make sure we have time for some of the comments or questions that I see coming in, which is great. Thank you. Continue to submit those. I don't think we're gonna get to all of them because there's a lot of good stuff. But let me skip down. Since launching this program, what are some of the biggest benefits that your providers or you've seen from your providers in your patient and that you've seen or you've experienced maybe? What are the wins? And then I'll start with you, Dr. Barr, and then anybody else. I know you've worked on many programs, Tom and Dana, so I'd love to hear if there's any others that you can share.
So many wins. On the one hand, I'll try to get through this. Even one story can be a major win. Okay, so I mentioned this in our panel we had down at Neuroflow last month or so. But in briefly, yeah, we had in our first week on NeuroFlow, a doctor give me a email from a patient who she had a prior history of suicide, overdose, coma for 4 days, neurologic damage, battled back, got everything back. She got a job, graduated, a family, and her depression came back severe. And she tried to go through the insurance channels, who's in my network, who has appointments, all these things. And every single one of those phone calls, and there was an answering machine, days waiting. This was a severe burden to her. Anybody in a severe depression, that is just torturing them. So all of a sudden, NeuroFlow comes, she signs up, answers the questions appropriately. Within 5 minutes, a behavioral health care manager from NeuroFlow is on the phone with her. And she's like, uh-oh, I did answer that question saying I thought about hurting myself. And he's like, no, don't worry. That's a normal thought. Let's talk. She's like, wow, you're not going to send me to the crisis center and institutionalize me? No, we're going to talk. And so after 25 minutes of talking, he sets her up with a psychiatrist in her network, has access in 3 days, and has even post-traumatic brain disorder expertise. She's like, you know what? You guys just made the difference in living or not. That's what NeuroFlow has done for us.
Wow. And I missed this the first time I heard that she wrote to the doctor, her doctor.
Yeah, because the invites for NeuroFlow come from the doctor, so we personalize it. Because you don't want to get an invite from a patient. A patient gets invites. Download this app. No, it's got to be personalized. You got to use your relationship through your providers to make this really happen.
Wow, thank you for sharing. Anybody else have a story like that?
Go ahead, Dane. I can see you, and I'll chime in after.
I might go just to articulate the broad spectrum of folks that can get served in these kind of interventions. I might go with something on the kind of the opposite end, where there was an intervention that we were running that did screening and comprehensive screening, and a patient flagged, as being very stressed and overwhelmed, not at the level of thinking she was going to hurt herself, but just that it was something that was frequently in her thoughts. And she got reached out to, connected with a therapist and a case manager. And as they dug into it, they uncovered all of these issues around her inability to access the medication that she was being prescribed for her hypertension, her confusion about other aspects of some chronic disease management that she had. And just having the space to talk about that calmed down her anxiety, but also provided rich information that the therapist was able to then circle back with her primary care provider, redo her chronic disease management protocol, get her switched to a medication that she could afford more, and things like that. And we saw that 6 months later, she was regularly engaged. She'd followed up with a cardiologist. She was fully engaged with that primary care team, but had been so stressed and didn't normalize that those were things that she could talk about in the primary care setting, because to her, they were manifesting in a way that's more, I have this anxiety, I'm worried about what's happening with my mental health. So I just think that aspect in terms of the benefits of we want to 100% catch all of the cases that Dr. Barr is talking about, but there's so many small gains that can happen just by having that comprehensive screening and that population approach.
Yeah, and I would add just a couple of points. So first of all, primary care has become the de facto mental health center for this country, right? About 80% of all antidepressant prescriptions are written by primary care docs. We know that about 60 to 70% of individual psychiatric illness present in medical settings. They do not present in behavioral health settings for the most part. And yet 95% of all behavioral providers work in primarily or exclusively siloed behavioral health settings. So we have a misalignment in terms of where we're providing the services, and it really speaks to the importance of integrating those services. And then when you look at suicide, and that's such a powerful story, Jim, and we've seen that, right? We've seen that with other clients, and we've seen that, the importance of responding when there are safety concerns. But what is really striking is, one, sadly, the rate of suicide is going up substantially. And so we're now at about 48,000 deaths per year by suicide. And when you look at suicide decedents. About 70% have seen a primary care physician within the past year. About 40% have seen a primary care doctor within the past month. Those numbers are about twice as much as seeing a mental health provider. So, you know, we can't say, let's just refer patients when there are safety concerns to behavioral health providers. There are simply not enough behavioral health providers out there. There's a scarcity, a tremendous scarcity. So it really is incumbent upon primary care, like it or not, and medical specialties in general to screen, not just for depression and anxiety, but to screen for safety and have interventions that can help people in the moment. There's a growing literature looking at what's called ecological momentary assessment, the idea that you can respond to someone in the moment when they are in crisis to assess how they're doing and to provide them with caring context and support and so on. And suicidal ideation can be really fleeting, and often it can be literally minutes that are the difference between life and death. Not to sound overly dramatic, but it really can be true. And there's a whole literature on caring context and support you can get to patients when they're most in need. And that doesn't mean 10 hours later or 15 hours later. It means in the moment. And one of the things you can do with technology and what we do at NeuroFlow is that you can provide that support in the moment, either with the technology through a digital platform, and there are caring contexts that can be distributed and disseminated to individuals who are in need through all sorts of mechanisms in that moment. And then you can actually have live human beings who follow up with calls, which is something that we do or our clients do, where you want to talk to the patient, to do a full suicide assessment beyond the digital assessments. And there's something immensely therapeutic about that contact that also can be very helpful. So the point is, with technology, it's a way of extending what goes on in the practice and allows you to enter the patient's home at critical moments of time that speak to exactly what Jim just shared with us. And thank you for sharing that, Jim. It's a really powerful story. And that's something that we're seeing a lot of. So, and lastly, I'll say this, that what we've seen when you integrate psychiatry, behavioral health in these models, collaborative care and other models, is that provider satisfaction, as we said, goes way up. But we also see that, well, maybe it's one of the reasons provider satisfaction goes up, is that the administrative toll on the providers goes down. There's a lot of trepidation because in some of these models, the physical medicine, the primary care doctors, and others are doing the prescribing. But the reality is the burden and the toll, the administrative toll that addressing these problems in medical settings takes goes way down, because you're really helping people to get better. And what you see is that patients are getting better, and it leads to improved health outcomes and decreased utilization, decreased facility billing, decreased costs. So it really becomes a win-win.
Thank you. So we have about 10 minutes left, maybe a little bit less than that. Let's get into some customer questions, or excuse me, some attendee questions here. So I looked at the earlier who was registered, and not everybody's part of an ACO. So one of the questions was about, how does this work? You know, what transfers over to non-ACO models, and how does particularly the financial piece add up for organizations that have a different model, fee for service or such? Who would like to start with that, Dana, or?
Yeah, I'm happy to speak to that. So I think that it's a really good question. I mean, you have to dig into it, and it does vary depending on the state you're in, depending the market you're in, the payers you work with. But I think overall, across the country, there is a growing focus on paying for outcomes related to behavioral health and substance use on both the access and improved experience of those diagnoses. In addition to things that are happening in terms of, value-based contracting or paying for outcomes on the private sector or Medicaid or Medicare side, a number of states are utilizing their 1115 waivers or DSRIP programs to incentivize behavioral health access. So there is an influx of funds that are outside of the typical payer model that are specifically focused on increasing access to these areas. And I think that there really can be an internal look within your system of saying, how do you align these different incentives? Where can you bill for services? Where can you participate in quality programs? And where can you really, to the theme that's been echoed over and over, track your outcomes of the patients that you're working with to actually get gains on the chronic disease and other types of incentive programs that your system might be participating in. I think we could share out, there's a resource that the National Council on Mental Health Wellbeing has done that is a decision-making support tool for folks that are trying to estimate Medicaid Medicare reimbursements for various behavioral health services to help kind of make the business case for expansions in those spaces. So we can share that out as a resource for folks to take a look at. And it's you can filter it by state to look at the specific reimbursement codes and amounts within your region.
Yeah, and I would echo that 1,000,000%, Dana. So thank you for that. I mean, there are, people think about value-based purchasing arrangements as being monolithic, and it's not. I mean, there's the Innovation Center, the Center for Medicare Medicaid Innovation, that's doing some really interesting stuff. Dana, you touched on that, whether it's it was CPC plus, comprehensive primary care, to primary care first, to making care primary now. Now those are regionally, those are regional programs. They may become national over time. There's an enhanced oncology model that talks about delivering oncology care in an integrated fashion and looking at all sorts of quality measures. So they're doing some really interesting stuff. And then you have, as you say, these 1115 waivers. I mean, in New Jersey, for example, there's a quality improvement program where Medicaid pays hospitals when there are screenings for behavioral health illness on maternity floors and psych units, and ensuring that patients get, and Jim, I know you know all about this, from acute care services to ambulatory services in a timely fashion. And health systems can garner millions of dollars, but it is very burdensome to do that without technology to track those outcomes and report those outcomes to the state. There are MIP, beyond Medicare shared savings, there are risk adjustment, there are MIPS payments, there are payments for screenings, there are lots of other ways to look at reimbursement. To be perfectly candid about this, I mean, it's wonderful having the fee-for-service reimbursement, and most carriers are now paying for it. It started with Medicare, most payers are paying for it, but they, quite frankly, are placeholders when you look at the downstream revenue. And I'm not just talking about ACOs. If you're looking at downstream revenue collection and generation for non-ACO situations, because again, value-based care arrangements are not monolithic. There can be all of these other pay-for-performance metrics that are out there from CMS, and now payers are doing it as well. There's payer-sponsored collaborative care, actually. So a lot of stuff. And I think that's a great question and an important point.
Thank you. So we have one more question I think we have time for. I'm going to combine it into two, and I'm going to ask Dr. Barr this. What kind of investments did you have to make around the technology? And then what's next for your organization? Where are you do more of this, or what does it look like?
Yeah, so we started, we call it, again, I'm stealing this from Chris Malero, but the landing phase, not a pilot. No. Now when we landed in Normandy on the beach, we didn't pilot whether we were going to attack or not. We went in, and then you expand from there. So that's the mentality that we use. Our landing phase is 15 practices, up to 50,000 lives. So right there, these were a combination of practices. 8 of them are on Epic in their ambulatory offices, and the rest were on 7 different EMRs. Okay, so the technology investment based on your EMR, no. I mean, there are certain EMRs that are easier to integrate with your NeuroFlow, workflow and data and sharing, especially when it comes to collaborative care services and everything. Yes, there's certain APIs and everything that, it's easier than other, EMRs, but we don't have any of those EMRs, including Epic right now in the first landing phase, integrated. Okay, so you can do it even without your EMR technology investment or any other cost for interface, no cost for interfaces or anything. We started with the plain technology platform cost of NeuroFlow, because the platform is able to be given to every patient, does all the screenings, assessments, trackers, develops into a registry dashboard that we didn't have to purchase or build a dashboard. It's all NeuroFlows. Their behavioral health care manager and psychiatrists use that dashboard to track patients and then have meetings with our offices as needed. Certain patients are going to need more time to talk about and others don't. It could be very short, brief, it could be long. So there was no technology investment. We pay for the technology platform, which also includes NeuroFlow's response services, which is what I just described in that one patient. Because again, we're not, through this mechanism, giving one-on-one in-person visits with a neuroflow psychiatrist or therapist, okay? They are working collaboratively with us as primary care doctors to make this all happen. But if they need a psychiatrist or therapist, we have our own health system psychiatrists and therapists we refer to. So no added FTEs, no added technology. We pay for the platform, and then of course for the collaborative care services. When that gets involved, it wasn't required anything on our side. Now, yes, we have big plans. Okay, those 50,000 patients are going to expand to 500,000 over time. Don't worry, Tom, you don't have to hire that many collaborative care managers right off the bat. But we'll expand to 500 because every patient deserves this, needs this. And then number two is we're going to use our AWS cloud environment data for full integration with NeuroFlow data so that we can have the most personalized narrative with a patient ongoing. We're going to understand them, know them better than we ever have in the past. And at the same time, be able to use our AI and ML and all the other things to predict which patient is the next one. That, oh, Dr. Barr, get Mrs. Jones in your schedule tomorrow morning. And if I hear that from my behavioral health care manager at NeuroFlow, I will come in early and make sure it happens.
That's fantastic. I wish I could ask more questions. Thank you all for joining. For everyone that has attended or registered, we will be sending out a recording to this, so look for that. Thank you so much, everyone. Really appreciate you guys joining us and having this discussion. For those of you that asked questions and we were not able to answer them, which is a number of them, I'll share them with this team and see if we can get you answers. But thank you so much. Have a great day, everyone. Really looking forward to maybe another conversation in the future.
Great.
Bye.
Thanks, everyone.
Bye, guys. Thank you.